This LIT video is on uterine fibroids. In this video, you will learn the definition of uterine fibroids, the clinical features patients present with, as well as investigations and management of the condition. Fibroids present as benign growths of uterine muscle. They occur commonly in women of reproductive age. They are also known as leiomyomas. Leio means smooth, myo means muscle, and oma means tumor. Fibroids commonly present at 30 to 40 years of age. They are the most common non-cancerous growth in women, and they can develop in women of any age after the onset of menstruation. The incidence of fibroids increases with age. By 40 years old, more than 50% of women would have one or more fibroids. After menopause, fibroids tend to reduce in both size and number. The risk of malignancy into leiomyosarcomas is low, at 1 in 1,000. Risk factors for fibroids include increasing age until menopause, African and Caribbean women, and a family history of fibroids. There might also be an association of fibroids with low parity and infertility. Fibroids are defined by their location in the uterus, mainly subserosal, which is on the peritoneal surface or perimetrium of the uterus, submucosal, which is under the endometrial lining of the uterine cavity, or intramural, which is within the myometrium. Microscopically, they are smooth muscle bundles, and they are monoclonal, meaning they arise from a single cell of the myometrium. Depending on the type of myoma and their locations, symptoms and signs may vary. Many patients with fibroids are asymptomatic, with incidental findings of fibroids on ultrasound scans. Common clinical features include menorrhagia, abdominal pain, and dysmenorrhea. Especially in submucosal or large intramural fibroids, sometimes menorrhagia is severe enough to cause anemia.
Pressure on urinary and gastrointestinal tract can cause
pain, urinary and bowel symptoms, bloatedness, and dyspepsia. Submucosal fibroids may result in subfertility, which is a delay in conceiving, or recurring miscarriage by interfering with implantation.
Red degeneration of fibroids can occur in 10% of pregnant patients and can result in increased fibroid size associated with symptoms such as pain or fever. Fibroids in pregnancy can lead to increased risk in preterm labor, placenta previa, placental abruption, or fetal malpresentation.
Diagnosis is usually confirmed by pelvic ultrasound scans done transvaginally or abdominally. If further information about fibroid position, size, number, and muscularity is required, MRIs could be considered. Hysteroscopy will be useful to visualize submucosal fibroids. Also, biopsies are rarely done, but may be used to rule out uterine sarcoma. Treatment must always be tailored to a patient's
severity of symptoms,
reproductive status, and personal preference. Treatment can be expectant, medical, or surgical. Expectant management is acceptable if the patient is asymptomatic and the fibroids are less than 5 cm in size. Follow-up ultrasound scans, which can be done 6 months apart, may be done to monitor the growth of fibroids during reproductive age. Next, medical management aims to reduce symptoms or decrease fibroid size. Menorrhagia can be treated with tranexamic acid,
while dysmenorrhea is relieved with non-steroidal anti-inflammatory drugs.
If both menorrhagia and dysmenorrhea are present, NSAIDs should be the first-line treatment of choice. Fibroid size reduction can be achieved with GnRH analogs. Pre-treatment 3 to 4 months before myomectomy or a hysterectomy can be considered if fibroids are causing an enlarged or distorted uterus. However, GnRH analogs cause low estrogen levels, causing side effects such as menopausal symptoms and accelerated bone loss with an increased risk of osteoporosis. Hence, the maximum treatment period is 6 months. A small study involving 5 women has shown that the Mirena intrauterine contraceptive device was effective in reducing fibroid size. However, further studies need to be conducted before it can be recommended as a treatment for this purpose. Surgery is indicated when medical management fails. The type of surgery will depend on a patient's age, parity, and desire to conserve the uterus. One can opt to remove the fibroid alone via myomectomy or remove the whole uterus via a hysterectomy. There are various approaches to each surgery. Myomectomies can be done via open surgery, laparoscopically, or hysteroscopically. Hysterectomies can be performed vaginally or abdominally via open or laparoscopic methods. To decide the route of approach, one must factor in the presence of other gynecological conditions or diseases, uterine size, the presence and size of uterine fibroids, the mobility and descent of the uterus, the size and shape of the vagina, and history of previous surgeries. Hysterectomy should only be considered if other treatment options have failed. Some considerations are amenorrhea, the patient no longer wishes to retain her uterus and fertility, or by patient's requests. When counseling a patient, it is important to give them all this information to help them make an informed decision about which procedure is most suitable for them. This table compares the advantages and disadvantages between myomectomy and hysterectomy. The advantages of a hysterectomy include no risk of further recurrence compared to myomectomy with a high patient satisfaction. However, future fertility is not possible, and the surgery is generally longer and more complicated than the myomectomy, resulting in a higher risk of complications. The following table compares the advantages and disadvantages between the various approaches for myomectomy. In general, laparoscopic myomectomy has a more rapid recovery with a shorter hospitalization stay, less post-operative pain, and less post-operative adhesions compared to an open approach. However, laparoscopic surgery is technically more demanding and special training is required. Laparoscopic myomectomy is recommended for gynecologists who are good at laparoscopic suturing. The size of the myoma selected for the laparoscopic approach should not be greater than 10 cm in diameter. Hysteroscopic resection is recommended for submucosal myomas under 4 cm in diameter. Its main advantage is that it can be done as a day surgery procedure. There is no abdominal incisions. An alternative to surgery is uterine artery embolization, which involves complete occlusion of both uterine arteries with particulate emboli. This serves to decrease fibroid size by 40% to 70%, with improvement of symptoms in 80 to 90% of patients at 1 year. Major surgery is avoided with minimal blood loss, a shorter hospital stay, and quicker return to daily activities. On future fertility, miscarriage rates are higher in patients without fibroids, but there are several cases documenting successful pregnancies post-embolization. Magnetic resonance image-guided ultrasound ablation of uterine fibroids is a non-invasive technique, where fibroids are located under MRI guidance. An ultrasound energy is then used to ablate the fibroid. This is an option for patients who wish to avoid surgery. Quiz time. Question 1. Which is not a risk factor for fibroids? Noting that fibroids are linked to steroid hormones, the answer is having very few menstrual cycles. On the contrary, having many menstrual cycles is a risk factor for fibroids. Question 2. Which is not a viable treatment option for fibroids? A. Uterine artery embolization. B. GnRH analogs. C. Hysterectomy. D. Observation. Or E. None of the above. All of the above are viable treatment options, and it depends on a variety of factors such as the patient's choice and the severity of symptoms. Thus, the answer is E. None of the above. This is the end of the LIT video. Further reading references are as stated.